Hey,
Hi,
Sharon. Good morning.
hey, how are you?
Good. It says that I can't start my video because the host has stopped it.
I think there's something wrong in the settings. Let me ask my the IT person to help out.
Okay.
Yeah, Abhishek, I think you're on this, right? Can you please help him or change the settings because
Can you just who's this? Who is not able to?
the is the speaker for the evening. He's promoted to be a panelist.
Yeah,
Yeah, can you allow him to present?
yeah, okay.
Dr. Muthusamy, in case, just as a backup, do you want to send it to me, like Dropbox link or something? So I'll just download it, worst case.
Yeah, I've already
Now,
uploaded
now
to
we can
Drop.
present.
I can present. Okay, let's
Yeah,
try it. Start video. Yes, yes, perfect. Good to
Okay,
see you.
nice to see you.
Good
Do you
to
want to
see you.
share the
Thank you
screen
for
or something? Yeah, let's try that.
what? Perfect. And let me try the share screen just to make sure everything works.
Okay, fantastic. Looks
Hey,
great.
it actually worked. Okay.
This is,
So should I just leave? Should I leave it like this? Is that good?
yeah, that's fine. That's okay. That's not a problem.
Okay.
I
Or I
mean,
can take it down if you want.
uh, yeah, if you can take it down for a second, since it
Sure.
seems to work right now, I'm going
No
to,
worries.
yeah, I'm just
Yeah.
going to put the sort of future events flyer just so that people know
Yeah,
what
yeah.
is going to happen. So thank you for your early morning start for you, I guess.
Yeah, it's a long day for me. It's even though I'm after I'm done with this, I don't know if you've heard in the U.S. There's something that has sort of taken off during the pandemic called scoping Sundays.
I
Uh,
heard. Yeah.
yeah, so I'm the scoping Sundays guy today too at 11.
Oh,
So
wow.
I'm doing two.
Yeah, so I saw that there's a pancreatic cystic lesions thing that's planned.
Yes, exactly. That's right.
Uh, your favorite topic, I guess. One of your
Yeah, so
favorite
I'm gonna go to bed at 1 o'clock and call it a day. So
topics. All right. So yeah, today,
wow, look at you. You got I see you've got the team Mayo out in force.
yeah, these we had the Cornell folks give the talks earlier, and yeah, this is all Mayo Clinic here.
Well, congratulations. Wow, what a lineup.
Yeah, it's pretty good that you know we're able to hear you from a distance. But we definitely want to have you here next time. It's due,
Oh
I
yeah.
guess.
I'd love to come. I actually took my first work trip in 15 months last week. I went to give a talk in Washington State on
Oh,
Tuesday. And I hadn't traveled for work since March of 2020. So it's been a
uh,
long time. Felt good. So
yeah, I know. I can't wait for real, live events. There's something that's coming up end of the month in Pune. I hope it works out because we're all a little bored of this. But anyway,
yeah.
it's still great. I mean, uh, there, there's still a lot of people coming in. Still, it's been pretty good so far. Today,
Good.
unfortunately, it's clashing with another event that's ongoing as we are speaking. So I guess
Mhm.
a bit of a downer, but that's fine. We'll have.
Oh, you're talking about your attendance for this?
Oh yeah, today we didn't know, but there was another event also going on in parallel on pancreas, which I heard last week. So
Gotcha, gotcha, gotcha. No worries. Yeah, that's fine. How's the pandemic going in India now? Things are better.
yeah, it's actually it's really good here. I mean, as of
Oh,
now,
good.
it's hardly out there, and the problem is there's some Delta variant, which is a bit of a nuisance. So maybe next week they're going to have lockdown here locally. That's what I hear. So anyway, so hopefully at some point these things
And
will
on
go.
it goes, right? Yeah. Well,
Yeah,
let's keep getting vaccinated, and hopefully these things will subside. Yeah, it's actually pretty good now in the United States after being bad for so long. It's actually
Yeah.
we in January in Los Angeles County we had 20,000 cases just in Los Angeles County for 10 million people a day. Now for the country of 330 million, we have about 12 to 13,000 a day. So
Wow.
so better, definitely better.
Yeah, it's hard. It's in India where everybody's so close to each other. You would imagine the transmission rates will be much higher.
Yeah.
In the US, when everything is so spaced out anyway, still it's fine. Anyway, how's everything back at UCLA? Things are good.
Things are good. We just Jen Fan, our trainee this year, is just about to graduate. Tomorrow's my last day with her, so I'm feeling sad, as I always do at this time of the year. But she's taking a job at USC, so she'll be close by. She got a good
Ah,
academic job. So and then on Thursday we start the cycle repeats.
do you have two fellows or just one fellow now?
Just one, yeah. We just have one. We may have, but the big news is I made a big presentation to the CEO and the vice chancellor,
Yeah,
and I think I got a new 8-room lab approved. So hopefully in 5 years you'll visit us in our state
super.
of the art, lab. So we'll see. I mean, but I think we made a good case that
Yeah,
we don't.
yeah.
We're doing a lot more TIFF now. I've started entering. I'm starting to do some Zenker's cases, a little bit more suturing than I had. I mean, Ollie still does all the poem G poem, but
Yeah,
Adarsh
yeah.
is doing some bariatrics. So yeah, we're coming along. We're coming along.
Oh, awesome, awesome. Yeah, I know. I think missing Watson, I guess, the, those days, but it's been a long time now, right?
Yeah, you were here. What? You graduated 16?
I think so. Uh,
17. Yeah, you've
17.
been back a couple years. Yeah, seems like yesterday.
I know. All right, so maybe I'll just get. Let's see what's going on with the panelists. Dr. Ramchandani, I think he's in another one. Let me add Vikas up as a panelist here. And who else? Let's see. Dr. Praveer Rai. I'm just going to call him, just a reminder. Oh, hi, sorry. Abhishek, can you please allow everyone to show the, start their videos? Yeah, can you ask everyone?
Hi, Dr. Saurabh.
Sorry, I'm mute, I guess. Vikas, hi, hi.
Hi, how are you? Hi, Dr. Ramam. Hi, Dr.
Hi,
Ramam.
how are you, Vikas? How are you? Good to
I'm
meet
fine.
you virtually.
Yeah. I think it's a very good topic. ERCP, always very interesting.
Yeah. Always more capabilities, more challenges, tougher cases.
Yeah. Sorry, I asked you to squeeze a little bit too much in that talk, but hopefully that should be good.
I covered everything at a relatively high level. We can dig into questions maybe during the other stuff, but I think hopefully you'll be happy.
Yeah. Okay. I guess my dad's here. Let's say I guess I can start with the introductions and then get going. So because we have a case which will take some time to discuss as well.
Saurabh, my video is not starting. I don't know why.
Yeah. Okay. Let me ask Abhishek. Sorry, our usual IT person is not there, so I think this is like a backup. Abhishek, can you please allow Dr. Mohan Ramchandani to start his video? Let me just get that squared away.
Yeah, hello. Saurabh.
Yes. Can you please help?
Yeah, I'm doing that only. I have made them co-host. They can just they can just click on that video icon.
Okay.
I've allowed them.
I'm not able to allow starting my video.
Yeah, me too.
1 second. Can you try now?
Right?
Yeah.
Fine.
Okay. Sorry. Sorry for that, everyone. Okay. Dr. Datta, thank you for joining. This is
Hi.
Yeah.
Thank you. Looking forward to a wonderful evening with all of you.
Thank you, sir.
Hi, Usha. Hi, welcome.
Thanks.
Okay.
Hi.
We got the video started right now.
Everyone can start, right?
Yes, I think we are good right now. So let me just sort of start the introductions, I guess. Thank you. Hi, good evening, everyone. It's a Sunday evening. Thanks, everyone, for joining in. We have the pleasure of having Dr. Raman Muthusamy today, who's from the University of California in Los Angeles. He's a professor of medicine and director of the endoscopy unit there. He's my mentor, and I have the privilege of working with him and learning all I know from him during my training years. So Dr. Muthusamy is a recognized leader in advanced endoscopic procedures. His clinical research interests focus on the evaluation of existing and new endoscopic technologies for diagnosis and treatment of digestive disorders. He's especially interested in ERCP with a particular interest in cholangioscopy, stent placement, and device reprocessing. He's participated in numerous studies involving the development of quality metrics in endoscopy and methods to improve the efficacy of and safety of endoscopic care, and including leading a multi-center evaluation of the first single-use duodenoscope, which is now available in the market. He's board certified in gastroenterology and has been frequently recognized by best doctors since 2011. He's a fellow of the ACG, ASGE, AGA, former member of the ACG Research and Public Relations Committee, currently serves on the Educational Affairs Committee for the ACG, as well as an associate editor for the Red Journal. He's also previously served on the AGA's Research Awards panel and is the immediate past chair of the AGA's Center for GI Innovation and Technology. He has more than 150 research papers in peer-reviewed journals. So thank you, Dr. Muthusamy, for sparing your time on a super early Sunday morning. Thank you.
Yeah. Yes, it's great to see you, Saurabh, and very nice to be here with everyone. And I thank you for the opportunity to chat with you today a little bit about ERCP. I'll go ahead and share my screen.
Yeah.
And let me know if you all see that.
Yeah, Dr. Muthusamy, I'm just going to introduce the panelists for the evening, and then we can start if that's okay.
Yes, of course.
Yeah, right. Yeah. And we also have Dr. Mohan Ramchandani from AIG Hospital in Hyderabad. He needs no introduction in India and abroad, I'm sure. He has a long experience of more than 20 years in the field of gastroenterology. He's the director of interventional endoscopy at AIG hospitals. He's trained in various therapeutic training centers like Northern Yokohama Hospital in Japan and Zhongshan Hospital in Shanghai. He's an expert in advanced procedures, third space endoscopy, cholangioscopy, ERCP, with a very vast experience and is recognized as an international expert in the field. He's been invited world over for his expert skills in endoscopy workshops. He is authored multiple publications in national and international journals. He's on the editorial board of Video GIE and peer reviewer in many GI endoscopy journals. So thank you, Dr. Mohan Ramchandani, for joining in today. We also have Dr. Vikas Singla, who's the director and head of gastroenterology and endoscopy at Max Super Specialty Hospital in Saket, New Delhi. He's trained at AIIMS for his MD and DM and has large experience in advanced endoscopy. And he's a prolific endoscopist and he's published more than 40 papers in peer-reviewed journals. We also have Dr. Pravir Rai, who is joining us from SGPGI in Lucknow. Again, a very experienced senior endoscopist, very active in therapeutic endoscopy and has a large experience in interventional endoscopy as well. So we'll have Dr. Muthusamy present, give his talk, and then we'll have an interesting case, as we've usually had in our prior events, where we'll discuss some routine challenges that are encountered by most gastroenterologists. So thank you, everyone, for having us. And we have, and thanks, Dr. Datta, for joining in today as well, all the way from PGI. Thank you, ma'am. Thank you.
Okay, great. I'll go ahead and start then, Saurabh. These are my disclosures, and it's an honor to be here with your distinguished panel today. So I'm going to go ahead and let's see if I can forward this. Okay. So, my overview of my talk today is you asked me to speak about three areas, somewhat briefly, and I'll cover them at a relatively high level. Performing altered anatomy, ERCP, a bit of a discussion about cholangioscopy, and then a management of hilar strictures and stenting. And obviously cholangioscopy is a fairly big topic, so I ended up spending most of my time really talking about assessment of indeterminate strictures, and I really didn't speak a huge amount about stones, although certainly it's important for lithotripsy as well. And then we'll have some conclusions. So I'll start with altered anatomy, ERCP. There is an excellent reference for those of you who may be looking for one. This is from the ASGE Technology Committee on Devices and Techniques for ERCP in the Surgically Altered GI Tract, and I certainly used a good component of some of these diagrams and information from the document. So these are some general tips for successful altered anatomy ERCP. I think the key is, of course, is to make sure that you understand the post-surgical anatomy whenever you can. A lot of times the operative report may not be available. The surgery may have been done some period of time ago, and it may not even be a type of surgery that's even performed anymore. So you really want to try to find the operative node and available imaging as much as you can, and if possible, even consider discussion with the surgeon as to what you might see. Based on that information, then, it's really important to know what type of endoscope you're going to need, and that will determine based on the anatomy and local expertise that's available. And importantly, your choice of endoscope will determine your choice of accessories, because if you have You know, some stents are going to allow you to use the standard duodenoscope accessories. Obviously, if you start using colonoscopes or longer endoscopes, you know, that are 200 centimeters, you're going to have a much more limited number of options of tools. And so it's important to know what you can and can't do with the type of device that you're going to use. Now, if you're using a non-duodenoscope and you're using sort of an end endoscopy device, you may want to use a clear cap, which I think really helps in some ways navigating these folds. And frankly, it's quite helpful in just simply trying to find the anastomosis. Some of these orifices are quite small. They're very difficult to find nestled inside of folds, particularly if they're stenosed. Which may be the reason you're there in the first place. And so using these devices can be very helpful, both in finding and navigating tight turns, but also for stabilization at the time of procedure performance. And I would say that, again, it's important to consider the use of fluoroscopy as you're advancing down you know, the anatomy to help identify your pancreaticobiliary limb. So here's a case I did a couple of weeks ago where you can see this was a patient who had a hepatico-jejunostomy due to a bile duct injury. And you can see that we were going down a ways and we obviously missed sort of the turn, because you can see we've got quite a bit of scope in and yet we're not headed in the direction. You can actually see the air cholangiogram here. This was a patient who had a suspected stenosis, turned out not to. But you can see the air cholangiogram, and you can see that I've pointed that with the white arrow. And the black line actually shows that you can actually see the air entering the bowel here. Here's the end of the limb here, right here. So you know that when you're getting close, you're headed up in this direction. So I think that's always, you know, using pneumobilia when present and knowing just from fluoroscopy if you're headed in the right direction, a good way to tell. So some tips, additional tips for successful altered anatomy ERCP. You know, I think sometimes considering changing the position, straightening maneuvers, and application of external abdominal pressure to minimize loop formation to assist in endoscope advancement. So these are things particularly almost standard enteroscopy type skills. If you're going to have to come back again, perhaps in the future, it's common to tattoo, you know, the relevant limb, usually the afferent limb in a B2 or your pancreaticobiliary limb, just so that you avoid, you know, having to kind of figure out which limb it is again. Consider, we generally tend to use anesthesia for all these cases anyways. Carbon dioxide insufflation certainly helps because they can be long procedures and there's less sort of gaseous distension. And again, sometimes when you're using tools, particularly when you're using accessory devices that run through long, you know, scopes, you may want to manually reshape or groom certain accessories that may help facilitate cannulation. And understandably, these are not your standard procedures, and you really should allow adequate time. Particularly if this is your first time scoping the patient, you may not know exactly how long the limb is, which scope, how loopy they are. So it gets a little bit easier when you're doing follow-ups on them, but certainly you should provide adequate time when you are doing your initial procedure. So what operations can undergo standard ERCP? It's important to know. So these are surgeries that if they've occurred, you're good. You can still use your standard duodenoscope. So obviously an esophagectomy with a gastric pull-up. Sleeve gastrectomy, which in the United States now, fortunately, I think for biliary endoscopists, has become sort of the dominant sort of bariatric procedure. Vertical gastroplasty is an older procedure that's very rarely, if ever, done these days, at least in the US. Laparoscopic adjustable gastric band placement was quite in vogue around 10 years ago, but has dropped dramatically in recent years in the US. Billroth 1 is a relatively outdated procedure. And of course, the choledochal duodenostomy doesn't really change the luminal anatomy, and so can undergo normal ERCP. So now I'm going to transition a little bit to talk about the most common types of altered anatomy here. And so one is a Billroth 2 type anatomy. This is the kind of procedure where you've essentially got an afferent and efferent limb. The efferent, of course, is heading to the anus. The afferent is where you'll see the ampulla and have access to the pancreatobiliary tree. So generally here we're going to use the duodenoscope, but you can also use a gastroscope, but just recognize, of course, you won't have an elevator. Typically from the area of the anastomosis, it's about 30 to 50 centimeters from there to the papilla. And you're going to have a caudal approach to the papilla. You're coming from below, so everything is inverted 180 degrees. So normally we want to cannulate the bile duct at 11. Now it's actually headed off to 5. And so there's a couple of ways you can manage that. One of the company's Cooks makes a dedicated Billroth 2 cannula, or you could find a rotatable sphincterotome, Autotome by Boston Scientific, or you could use swing tip, and these are things that may be able to allow you to access, get it oriented and have the sphincterotome flex in that direction. You could also use a standard cannula and cannulate, and if you get a wire in, then you can place a stent and then do a needle knife papillotomy over the stent in the direction of the bile duct at 5 o'clock, or you could do balloon papilloplasty. Now, when you're going down, one of the first questions may be, well, which limb do I go down? And sometimes, to be honest, it's a little bit of trial and error. My general rule of thumb is, look to see if you see more bile or bubbles in one than the other. And my experience is that it's more often than not the one on the right or the one that's a little bit more angulated. So if it's straight and off to the left, that's probably the efferent. So in this case here, in this picture, I would think that the maneuver here would be to move to the right. Although, again, all of these things are subject to some error. And again, fluoroscopy can be helpful as well. So here's what you're looking at when you come in from underneath. So now, again, a normal anatomy, if you're coming with the duodenoscope, you'd say, well, I'm going to go for 11 o'clock and cannulate. But if you're coming the other way here, like in a Billroth, you're actually going to try to cannulate in this direction. So you want to maybe get engagement and then flex into the 5 o'clock area. And again, there's a variety of ways you can do that. You can sort of you can cannulate, you can balloon dilate, you can do a needle knife papillotomy kind of in that direction. You can place a stent and do that. So there's a variety of different approaches that one can take. Now, this is not a variant I've seen very often, but there's a Braun variant of this where they've essentially done a jejunojejunectomy on the side with the idea that you're going to divert some of this bile this way without actually coming into the gastric stump. And this idea is to reduce some of the bile reflux adverse events associated with sort of a standard B2. This can lead to some confusion because you end up coming out one, and then depending on if you take the wrong turn here, you'll end up back and retroflexed into the stomach again. So this can be an area where, there's essentially 4 potential pathway, well, 3 from the one you're in and then the 3 others. So again, it can sometimes be a little bit longer afferent limb as a result of this, and so you may need to use a colonoscope. Or I should mention now there is a short double balloon device which can be utilized to, the main advantage of that is that it can use standard accessories, and so duodenoscope accessories. So you might want to use that scope. But traditionally, you can either use a duodenoscope or a gastroscope in these Billroth 2s. Now, I'll transition to talking about Roux-en-Y hepatojejunostomy. This is a procedure that we often see done as a result of patients who've had some sort of a bile duct injury, usually from cholecystectomy. You may see essentially you'll often see a direct connection of the hilum. Sometimes there'll even be 2 holes because they'll actually just a little bit of the hilum here. Here in this schematic, there's 1. And so you essentially, what you'll see is you'll have your normal anatomy as you come down. You will have an ampulla, which is important to know that if you're doing a pancreatic indication, this becomes a normal ERCP. But if you're trying to do the bile duct, what you're going to end up doing is have to go down past the ligament of Treitz, and then shortly thereafter the ligament of Treitz, usually you will see a takeoff, and it was usually at a sharp angle, and then you'll kind of make your way back up, and then you'll have to try to find the bilioenteric anastomosis. So so again, these are some of, usually you need a colonoscope for this, sometimes an enteroscope. But in my experience, These take a little bit of effort, but usually we can get there. It's pretty rare that we can't actually get to the end of this. It takes a little bit of time. I typically don't necessarily need to use device-assisted enteroscopy for this. Usually a colonoscope or just a push would work. Now for Whipple resection, again, there's two variants. Saurabh, as you know, at UCLA, where the surgeons typically perform the pylorus preserving version. So you basically have a pylorus, a small amount of duodenum, and then a duodenojejunectomy, and then you essentially follow up the pancreaticobiliary limb to find both the biliary and the pancreatic anastomosis. The pancreatic anastomosis is usually not at the end, at least not the way our surgeons do it. It's off to the side as drawn here. I've seen some reports where it is an end-to-end, but usually I see it's it's more of an end-to-side anastomosis for the pancreas, and that can be somewhat hard to see. So the standard Whipple is where they actually do an entrectomy, and so you'll have a gastrojejunostomy that is present. So this afferent limb is usually about 40 to 60 centimeters, and usually your bile duct anastomosis is about 10 centimeters away, and I guess in this case proximal to the pancreaticobiliary anastomosis. Sorry, the pancreaticojejunal anastomosis. The PJ anastomosis, as I mentioned, can be hard to find when it's stenosed. A cap and fluoroscopy should be what that says. And again, you sometimes can use a duodenoscope, gastroscope, or colonoscope. I tend to use I start oftentimes with a gastroscope because I'll have the advantage of being able to use more instruments, knowing that I may not get there. And then usually my default is a colonoscope. I don't tend to use duodenoscopes so much, but some might. But we tend to use more of an end-using scope. So here's a case of an anastomosis that was a little bit stenosed and underwent balloon dilation for subsequent enlargement and then a stent placement. So the most complicated by far is the Roux-en-Y gastric bypass, which is again commonly encountered in the U.S. because until recently this was the main gastric bypass surgery. So you have this excluded stomach, you have a Roux limb, which by design is very long because it's intended for weight loss. And then you have the afferent or pancreaticobiliary limb here, and then you have the, and again, it's a normal ampulla, and then you have the efferent limb here. So usually to get all the way down here and then all the way back up, it's really going to be, an enteroscope more than likely. These limbs are usually 100 to 150 centimeters, sometimes 200. So you can try peroral ERCP with an enteroscope, usually device assisted. You could do a operative procedure where you have a surgeon create a port, a lap-assisted ERCP, and then try to go in here. If you do that, it's helpful to try to have the surgeon, if they can, try not to put the port right in front of the pylorus. It makes it a little bit harder to do the turns. If they can do it a little bit more proximal, that's nice. And then there's a couple of options. You can do endoscopic ultrasound guided anterograde ERCP, where you basically, through this remnant stomach, access the liver, get a wire down, and almost like an interventional radiologist do the procedure. And now recently, there's this edge procedure where we use lumen opposing stents to actually create an opening between into the excluded stomach, and then either at the same session or a subsequent session, advance the scope down, do the procedure, and then often later on can close the created opening with sutures. Suturing and go from there. So this is a table that, again, I'm certainly not going through this, but I just wanted to use it as a reference, which shows you all the different kinds of, all the different kinds of devices, needle knife, balloons, wires, stents, dilating balloons, etc., that are present, and knowing essentially a little bit about what lengths they have, 200, 320, and what might be available, particularly when you're using non-standard devices. So clinical success rates for these, Billroth 2 duodenoscopes, when you're using a duodenoscope, It's 70 to 97% for reaching the papilla, 60 to 91% for biliary cannulation. Forward viewing scope cannulation rate seems to be actually a little bit higher, 81 to 87. And that's mostly because it seems to have a higher rate of getting to the papilla. It seems to be that once you get there, it's roughly the same biliary cannulation, and you would argue that it might even be higher for duodenoscopes once you get there. But this advantage was because you tended to get to the papilla a bit easier with forward viewing devices. Roux-en-Y, interestingly, the published literature suggests that accessing the papilla is equivalent with single balloon, double balloon, and spiral enteroscopy. I have personally found spiral enteroscopy somewhat challenging to make the turns. We only actually have single balloon in my institution, although it's my impression that double balloon from most of my colleagues that I've spoken to does seem to confer some advantage. And if you take a look at the overall rate of success, at least in a large sort of systematic review, it's around 74%, but I think that is enriched in centers with expertise. I think the real community success rate is probably closer to 50% in my mind. And so we generally at our institution don't do enteroscopy assisted. We've typically done lap assisted, and now we're starting to use this edge procedure to do these in select patients. So that covers kind of the first third of what I wanted to talk today about. I'm now going to transition a little bit to cholangioscopy, and then perhaps, Saurabh, I'll take the questions at the end. So I'm going to talk now about cholangioscopy, and specifically, as I mentioned, it has a lot of indications, and with the quality of the imaging that we have, we tend to have more and more indications for it. So traditionally, it's been used to help assess strictures. Indeterminate strictures, which of course could either be benign or malignant, but are maybe are not obvious. You can use it obviously for complex stone disease, usually in the setting of performing lithotripsy, either laser or electrohydraulic. It can be used to assess PSC, dominant strictures, and occasionally an IPMN for preoperative evaluation. I will mention now that we're starting to use it in the pancreas for stone disease and to do this per-oral pancreatic intraductal lithotripsy, or POPL, which is being used, and we've actually had some great cases with that. And it's also got some other indications which I'll discuss towards the end of this section. So again, cholangiopancreatoscopy is direct visualization of the biliary or pancreas ducts, and it may have advantages over fluoroscopic imaging in detecting small stones, residual stones, breaking up large stones, of course, assessing for pancreatic stones. I think really I'm going to focus on assessing indeterminate biliary strictures and tissue sampling. It may be useful in certain IPMNs to assess the extent of main duct involvement, or if main duct involvement is present. Villus tumors of the bile duct epithelium, and again, perhaps in assessing filling defects for chronic pancreatitis. So cholangioscopy now is, about almost 50 years old. It was first done percutaneously, and then we started using it through the scope, really as a mother-daughter sort of, or mother-baby sort of scope that was there. It was initially done fiberoptic, so you'd have two endoscopists, and one would be doing the duodenoscope, and the other would sort of have an eyepiece and sort of look, and then it became video. We then had, direct endoscope-based cholangioscopy, where someone actually put an endoscope up the duct directly. And then we had this single operator probe-based cholangioscopy in 2005, sort of advances in slim upper cholangioscopy in 2010, and then digital single operator cholangioscopy in 2015, which has had a second version now, which has improved the imaging further. So here's kind of the old school way. You had sort of your primary endoscopist, and then you had your cholangioscope endoscopist as well. This was always very complicated. When I was a fellow training, we tended to use these. These scopes were very fragile in my experience. Obviously, they're fairly limited in what they can do. Small working channel, mostly for optics, and some in the early days were fiber optic. This again requires two operators, limited steering, no irrigation channels, highly fragile. And in the US, at least, it was limited access and not a lot of payment at that time. Then in 2005, as I mentioned, probe-based cholangioscopy came out with this device, which actually had different components. The optics was actually in a separate catheter, which was somewhat advantageous. You could sort of push the optical probe into narrower places than the entire scope could, but it was a little cumbersome to have so many different moving parts, and the optics were not nearly as good as they are now, but it did allow at least for a single operator. Now, for the per-oral cholangioscopy, again, we started with an ERCP. We performed a sphincterotomy using an ultra-stiff wire. We don't really use the anchoring balloon in the bile ducts anymore because there were some issues with emboli, air emboli with this. But over this wire, you can oftentimes put a small scope, and this allows for better optics, larger working channel, even narrowband imaging. And again, really, you should ideally, I think, carbon dioxide, definitely not air, when you're inside the biliary tree because of this risk of gas embolism. Or you can use water as well. And so these are some of the kinds of views that you can get on the right from this. So here's again the example of having put a wire in the stiff wire, and then you're advancing your scope over that and now into the biliary tree here. So these are some pictures there. Now you get some great images that you can get. Here's a sort of a cluster of vessels here, which I'll get back to, suggestive of a cholangiocarcinoma. Here's a small villus lesion here that was actually an adenomatous lesion, but not frankly malignant. As I mentioned, in 2015, there was a digital single operator cholangioscopy came out that had improved optics, completely disposable now. All the pieces were integrated and disposable, and allows for easier passage of a forceps through the elevator. And I'll sort of play these two videos here. This is kind of the old and the new. So this is on the left is sort of the 2005 version. On the right is the 2015 version. Hopefully you're have enough bandwidth here to sort of get this, but you can see there's a marked difference in this, and you can see this is a cancer. There's some tumor vessels that are located here on the right. So again, but you can see it's almost like you had cataract surgery or something in the difference between these two. And I would go that even the more recent version that you'll see in a second has even better optics. And we'll talk about what those, it's great to have that, but what are some potential implications of that? We'll cover that in a minute. So here's so you can kind of see the difference a little bit between the older and the new one here. So this is actually a video that we have for Video GIE showing the capabilities of some new devices that can go through. There's a snare and a basket and an improved enhanced forceps. This is not a cholangiocarcinoma case. It's not a tissue acquisition case. This is a case of a stent that was up the duct here, and you'll see that we are basically putting a camera up, and we're going to put a snare around the side flange here and grab this stent and pull it out, because this was a patient who had a couple of previous failed procedures in getting the stent out before referral to us. So you can see we've got the snare now around the flange, and again, you need pretty good optics to be doing this kind of work. I mean, you'd almost argue it almost feels like you're in the lumen with a regular endoscope. So so here we're grabbing this flange. You can see we have the flange now, and we're able to sort of pull this device out. It's actually a biliary tube here, a T-tube. So, and now you'll see it pop through the papilla, and there it is, and out. So these are the kinds of level of imaging now that we have. So in most cases, again, again, the diagnostic cables of ERCP we want a tissue diagnosis. Biliary strictures from either pancreatic or primary biliary malignancies are not uncommon. And again, these patients are usually going to undergo ERCP, usually for relief of obstruction, but also at that time, it's a perfect opportunity for stricture evaluation, both on cholangiography as well as perhaps direct imaging, and then tissue sampling of the stricture. And traditionally that's been with brushing or perhaps just forceps biopsy that are fluoroscopically guided, but it could also be from direct cholangioscopic biopsies. So ERCP again can provide your first opportunity to get this, tissue, and we'll kind of go over kind of the yield of this. So, as you know, brush cytology is not very sensitive. It's great if it's positive, but if you take a look at these studies, most of the time you're looking at probably a 30% sensitivity in terms of brush cytology. Now, what if you happen to do a sphincterotomy and get do just a regular biopsy forceps up there under X-ray guidance? Usually, you will probably be biopsying the inferior portion of the stricture because it's unlikely you'll get the forceps across. So you may not get the best part of it, but you get more tissue for sure. And the yield here was a little bit better. Sensitivity is around 44%, but still less than 50%. And there's been lots of sort of studies that have looked at sort of what is the different yields. Forceps biopsies in this group of 6 studies was, average 56%. But even with forceps and brushings, even when you combine sort of the two best things, it's around 55%, which means you're going to miss about half of the ultimate tumors, which is disappointing. And of course, bile aspirate and Stent cytology are fairly low yield. There are a lot of new things that are coming out, fluorescence in situ hybridization, using OCT or confocal endomicroscopy, which are, again, a little beyond what I'm going to have, the scope of what I'm going to talk about today. I'm going to focus mostly on tissue acquisition with cholangioscopy. So, this is a challenge. These tumors are often hypocellular, and there's often a desmoplastic reaction, which is common here. Cholangioscopy perhaps can allow you to better identify the key sites of concern when it will allow you to do targeted tissue sampling. And that can be used for, again, histology, but perhaps also for fluorescence in situ hybridization or FISH. So these are some pictures using the old cholangioscopy of different patients with tumors. Some have this sort of more papillary projection, but some will have this sclerotic, scarred sort of cholangiocarcinoma as well. So this is a little bit challenging. Now, what is, how do you tell with your visual that it's a tumor or not? And, there's tumor vessels are probably considered to be the greatest predictor, these sort of engorged sort of neovascularization. You may see a polypoid mass or papillary villus projections, but you could also see infiltrated ulcerated lesions or this stenotic type carcinoma where it's almost, intramural. And it's almost like I kind of view it almost like a Leonidas plastic in the stomach. It's actually a little deeper in the wall, and sometimes it's scarred and it's tight, but the lumen abnormality is not that much, and you can biopsy at the margins of the strictures. So again, in pictures, here's the big vessels. They're ectatic, they're engorged. Sometimes you'll see these small vascular lakes. Of course, there's a stricture, and you'll see this polypoid exophytic tissue as well. And so biopsying in these areas, I would biopsy, perhaps right in this area here at 9 o'clock as well. So these are all malignant strictures, and you can see they kind of, again, you see these sort of engorged vessels. That's sort of the main thing. And one of the hot areas right now, I know that, Sarab, you're having Mike Wallace come in a couple of weeks to talk about AI, is that there's a lot of work being done on AI to look at cholangioscopy to better sort of make visual impressions of malignancy, which I'll get to in a minute. So these are benign strictures. The main thing you notice is there's not as many blood vessels here. You see a stenosis, but the wall is generally smooth. And you'll see this for example, in ischemic strictures, certainly are a common sort of mechanism for this. So let's talk a little bit about tissue sampling with cholangioscopy. This was, I guess, a study, again, that I've alluded to in my prior slides. Aganoff did in patients with cholangioscopy, targeted biopsies, brushing, and standard forceps. And you can see here the overall sensitivity and accuracy is much higher in these patients with strictures using cholangioscopy. Again, in this study of 26, 17 had cancer and 9 were benign, and most of them were cholangiocarcinoma involving the proximal ducts. So targeted biopsies were felt to be better. And again, what's the best method for ERCP based in PSC? And the short answer is that again, cholangioscopy with biopsy, at least in the same, a different study here, excuse me, 96% for cholangioscopy. And again, you see brushings here, with 87%, I have to be honest, that is for accuracy. That's probably because most of these were negative, because I think brushings in terms of yield for sensitivity, quite poor. So, but again, the most accurate out of all these turned out to still be the cholangioscopy. So this is Dr. Ramchandani's data. Again, looking at 36 patients with indeterminate strictures. All received cholangioscopy with biopsies, and you can see they had a very high rate of accuracy for cancer, 21 out of 22, and they correctly identified 11 out of 14 that were benign as well, for an impressive 90% to 89% accuracy. Now, interestingly, the decision of accuracy was based in part on visual criteria as well. And you can see that the biopsies actually were about 82% accurate, which leads to a major point which I'd like to make, is that cholangioscopy visual criteria turns out to be better than histologic criteria. So, and I'll come back to this. So here's a systematic review of a variety of studies, including the study that I just referenced. 10 studies, 456 patients, overall sensitivity 60%, and as you'd expect, that the specificity is quite high. So when they called it, it was accurate. So the issue here is about missed lesions. The visual sensitivity and specificity were 84 and 82% for this study. Now, we did a systematic review with our group and looked at this, and we found something that, I think is carried across a lot of these studies, that the visual accuracy overall from a large number of studies is around 90%, but the biopsy accuracy is around 80%. And I think that's really the key issue here. Again, here's another sort of paper that sort of highlights this issue, that the visual impression sensitivity and specificity is actually better than the histology sensitivity and specificity. So we always, the famous mantra, tissue is the issue. But when it comes to cholangiocarcinoma, it may not be tissue is the issue. It may be your eyes are the best predictor. And so if you have, I always tell our fellows, and you probably remember me telling this to you, is if you suspect cholangiocarcinoma and you're negative on the biopsies, you're not done. You probably need to go back and resample, because usually your visual impression is more likely correct. So we did a study looking at what the new optics would be doing better with visualization with these biopsies. And we found that using cholangioscopic biopsy acquisition, we were able to do this quite well, 85%. And the yield of our biopsies, again, the sensitivity is around 85%, which is significantly better than brushings or forceps. And the overall accuracy was in 94% in our center in 40 patients that we did this on. So at UCLA for indeterminate strictures, what do we do? First thing is it's PSC or not. If it's a distal stricture and it's not PSC, frankly, we think that's probably either a distal extrahepatic cholangio or pancreas cancer. So we typically do an EUS followed by brushings if the EUS is non-diagnostic, often at the same session. And then cholangioscopy is reserved for rare cases where we don't get the answer with 1 or 2. For proximal strictures, the Mayo criteria suggests that that FNA of those lesions is a transparent, sample and should be avoided. So we tend to use ERCP with brushings, and then if that's often at the same time, do cholangioscopy directed biopsy and brushing as well. Usually we're not the first people to see these people, so we almost always go directly to 2. And then in PSC with low suspicion, we do brushing, but in high suspicion, we'll do cholangioscopy, brushing, and fish. Okay, future indications, we can optimize tissue acquisition. We may be able to do fluoroless pancreaticobiliary endoscopy by determining duct clearance with the device. Obviously, that is probably in extreme cases because cholangioscopes are expensive, but perhaps in certain patients, pregnant patients where you want to avoid, you might be able to use this. You could also use EUS. We've used it a lot to direct wire access for cholangiocarcinoma to find the ducts, gallbladder drainage. We also use it to assess the accurate extent of biliary tumors, because I think MRCP is not as accurate as people think. And you can do tumor-directed PDT, clear stones after complicated extractions to make sure there isn't residual, and assess liver transplant strictures. This is a case that we just published in the Red Journal, and I want to highlight this is some of the new forceps that are available for cholangioscopes. So this was a 71-year-old female who had a history of breast cancer in years past, quite distant actually, and then it presented with a biliary stricture in Las Vegas, about 300 miles east of us, and it had multiple ERCPs with stenting and at least 2 prior cholangioscopies with biopsies that were negative. And here you can see our cholangiogram here. You can see there's definitely a tapering here. I had done an endoscopic ultrasound which had shown some diffuse wall thickening in this region. And then we did a cholangioscopy, but again, this looks like the benign smooth strictures that I showed you. And I actually, after I did the procedure, I told the patient, I said, yeah, I think it's benign. I'm not sure why you have this. But I took biopsies, and it turns out that this patient actually had an intramural breast cancer metastasis. This is an ERPR positive stain here, and this patient actually had a metastatic breast cancer to the wall here. Now, this is really hard to diagnose with standard, cholangioscopic biopsy forceps, and so the point here is we actually were able to get enough material for immunohistochemistry and get into the submucosa with these forceps. So I think these are really a big advance in diagnosis. I mentioned the issue about using the cholangioscopy to assess hilar extension. And in fact, our liver transplant surgeons now typically request, even if we have a tissue diagnosis, a cholangioscopy to confirm the suspected MR or prior staging of bismuth classification to determine if they're a candidate for resection or if they're going to need perhaps transplantation. So sometimes we find that sludge has built up here, and that's actually overread as tumor going into a duct when it's not. And then oftentimes we see cases like this where there is subtle extension up a duct that is not appreciated on imaging. So in the last few minutes, I'm going to transition to talking about hilar strictures and stenting, and I'll cover this fairly briefly here. So again, your stent options for malignant biliary obstruction include plastic stents, as mentioned here, or uncovered, partially covered, or fully covered. You definitely, for hilar lesions, you want to use uncovered stents, and you might think that's fairly obvious, but just this week, I pulled out a stent that was fully covered, that was going into the left system and in the mid-hepatic duct, and then someone had put an uncovered stent over that to go transpapillary, and they had sort of jailed off the entire right system, and we had to spend some time clearing that up. So again, it's important to use uncovered stents or plastic. Know your biliary anatomy here. You've got the left hepatic duct, which is around 3 centimeters, usually the right hepatic duct going to the right anterior and posterior. And really, you're trying to figure out of these 3 main branches, right anterior, posterior, and left, how many do I need to drain? And these are my general approach for hilar stenting. Again, you want good preoperative imaging or pre-procedure imaging, ideally with a good MRCP. If you're planning on a surgery and they want decompression, you want to assess the need for preoperative drainage based on the bilirubin level. Usually, if it's more than 10, our surgeons want it. And then you want to figure out, you want to drain the remnant liver, the ones that are going to stay. So you don't have to worry about the things they're going to take out, but you ideally would like to drain the remnant liver. Many patients, up to half, should be acknowledged with hilar strictures, may need percutaneous drainage, so you have to have that understanding going in. And you don't need to drain atrophic lobes that are chronically obstructed. You really need viable liver, so you want to drain that. And you must obviously drain any segment you inject, so we typically tend to put a wire in to a segment, and then once we have wire access, follow it up with the catheter inject, and then that way we have guaranteed access with the wire. And the goal is that we want to drain at least 50% of the liver volume if resection is not planned. So you can see the right liver accounts for about 2/3 of the volume. The left liver is about one third. And so if you kind of break it into the thirds, right anterior, posterior, and left, you can kind of get a sense of volume with that. So again, here's MRCP imaging of a hilar stricture. And you can see the branches, of the right and then as well as the left here, and you can see there's a hilar mass. And so again, in our institution, the folks for preoperative drainage in resectable disease, when it's a large volume river resection, specifically right-sided lesions or an extended left, and we're already planning an ERCP for diagnostic purposes, or if the bilirubin is usually above 10 or they have significant comorbidities that are going to delay a resection. Here's the bismuth classification. Again, this is what we typically use to assess hilar tumors. If it's below the confluence, it's a 1. If it approaches the confluence but doesn't go up the right or the left, it's a 2. If it's up the right, it's a 3A, up the left 3B, and if it's up both, it's 4. And so the question then becomes, how many stents do you need? And again, this is where you really have to kind of look at your imaging to help you decide. If you've got a business 1, both of these things are going to drain as long as you get across the stricture. So usually 1 stent is all that's needed. If you've got a business 2, it just depends on how high up into this joint space it goes. If it's just to the very bottom, 1 may be enough. But if it starts coming higher up, you may need 2. And in general, my preference is to put 2 in if I can, right and left. Now for 3As, you'll usually need a stent in, I usually put one in the left, and then depending on if the tumor goes up to the confluence where the right anterior and posterior take off, or if it's below. If it's below, you can actually just place 1 stent because you'll drain both anterior and posterior with that stent. But if it's at that, to that point, you may need to try to get a wire in each and then place 3 stents. For 3Bs, like we are seeing here in figure C. For a 3B, which is on the left liver, usually we place 1 in the left and 1 in the right. And then bismuth 4, again, the same issue of how high does the right-sided lesion go up. So here's an example of someone who had 3 metal stents in this. I don't tend to use metal stents that much, but we'll get to that in a minute. So again, you have to interpret the cholangiogram. Here's someone where the right anterior, the anterior posterior, the blockage is below that. So 1 stent here will be sufficient to drain both, and 1 in the left. Here you can see they're separate. And so you're going to need 3 stents, 1 in the anterior, posterior, in the right, as well as 1 in the left. So metal versus plastic. Plastic is removable. They can vary sizes. Insertion doesn't impair future therapy. You can always add more stents if you need it, but they are less durable. Metal stents are non-removable because they need to be uncovered in this situation. They're really only for palliation in my mind. It's hard to add more stents. They are more durable, but it's really the reinterventions can be challenging. And we usually manage the reinterventions with balloon sweeps and then metal or plastic stenting or ablation with RFA. Should you place 1 metal or 2 metal if you're doing metal? And I would argue that you should do 2. There's improved stent patency, and there's also more reinterventions with just 1 stent. And you can see here that the clinical success was relatively comparable, but there were more reinterventions with unilateral drainage. And I think that there was actually some increased success with bilateral drainage, but the study was a little underpowered, so you saw a trend to that. So we tend to use plastics pretty much now because I find that patients are living longer with cholangio. I find it difficult to manage otherwise. And so, again, I tend to use plastic stents for preoperative drainage, of course. I only use metal stents when I think I can get it into all the nodes that needed. I don't usually place 3, but usually the type 4s that are, maybe 2 stents would be needed. And when I do put uncovered stents, of course, you need to use those. And I tend to like these sort of dual systems with 6 French systems where you can do parallel stents that go transpapillary. So you have 1 stent that's in the right, 1 stent in the left, and you have access. So I'll close this sort of whirlwind tour here by saying that alternate anatomy ERCP is challenging and that the key is preparation. Cholangioscopy has made great advances and markedly improved our ability to diagnose indeterminate strictures and achieve document duct clearance of stones. Hilar strictures are probably best managed with drainage of at least 50% of the functional liver, and you don't have to worry about atrophic segments. And again, I tend to use plastic stents and reserve metal stents for hilar strictures that are unlikely to need future endoscopic intervention. So with that, I thank you for your attention and the opportunity, Saurabh, and I look forward to chatting with everyone about ERCP.
Great, thank you. Thank you, that was a very lucid talk. Thank you so much. So just to move forward, what we'll do is we have a case that we can discuss and bring out some thoughts and in challenges that are faced when performing ERCPs in such situations. So we have Dr. Bhushan Bhavare. Bhushan, if you could start sharing your screen. Thank you. I'll throw the question at everyone.
I think meanwhile, I'd like to congratulate Dr. Raman for excellent lecture. I think that was one of the state-of-art lecture, and he covered very nicely the topics related to the altered anatomy, cholangioscopy. Can we ask some questions to him also? Or
Yes,
you
we can start with questions. Yeah, absolutely. Let's do some questions and then we can start the case. No problem.
Okay, so Dr. Raman, we do these procedure a lot, and I'll start with cholangioscopy. And the most important thing which we find is inter-observer variation of the defining the visual findings. At one consultant will come and say, "Oh, this looks like malignant, and this look like benign." So, do we have any structured classifications which reduces the inter-observer variations? Do you think they are the need of the hour?
Oh, absolutely, Mohan. That's an excellent point, and you're exactly right. Is that whenever you can see that we're kind of giving you a variety of criteria, but we don't have a point system. I know that there have been some folks looking to validate some scores. They're not widely used, and I'm very excited about the possibility of artificial intelligence. As we all have this, we can create a huge database of. In fact, I was just reviewing abstracts for an upcoming meeting, and I saw a paper that's looked at cholangioscopically, looking at an AI system looking at cholangioscopic videos versus diagnosis that was 98% accurate. So, so I think that what you say is a critical need, and whether it'll be ultimately criteria that we interpret, or perhaps maybe we'll just let the computers do it. Yeah. And I suspect that we may trust the computers more than ourselves.
Yeah, and most of our cases are being referred from the peripheral hospitals, and they've already done an ERCP and put a stent there. And by the time they come to us, there are some stent-induced changes which also confound the visual impression. That also is a big problem with. Do you feel a stent causes some change which can change our visual impressions?
Yeah, you can get I absolutely. It's funny you mentioned that, Dr. Ramchandani, because I just mentioned that lady that had the metal stent, the covered metal stent inside the bile duct in my talk. And so it turned out they had done some biopsies, but they had not gotten a diagnosis. So I had to pull those stents, and I had tremendous crush artifact, right? I mean, it was just necrotic, ulcerated. And even though, for all practical purposes, I totally believe it's a cholangio, with 8 SPY bite max biopsies, I did not get a diagnosis. And I think that's entirely due to what you just said, which is that it was just crush artifact. So we're treating her as if she is, and we will re-biopsy at her next stent change.
Excellent. Great.
Raman, it was a great lecture. Just a paradox that how the visual impression is given more importance over histology. Is it the sclerotic nature of the malignancy which makes the histology less sensitive over visual impression?
I think so. I see Dr. Ramchandani is shaking his head as well. I think, yeah, it's tough to get this. And I think, as we know, the numbers that I told you are all based on using those old forceps, which are very small and really rather inadequate. So that's why I think what we're seeing, I'd be very curious to see a modern cohort with improved visualization and bigger forceps. I think our numbers will be better, and I think we'll see that gap drop, but right now there's about a 10% difference. I'm hopeful that will come to near zero, but I think you're exactly right. It's just that we see it, but we just can't seem to acquire the diagnostic material.
I think we'll draw an analogy with sometime Linitis plastica. When we do an endoscopy, it looks like cancer, but we take biopsy repeatedly negative. And we use a better technology to get the tissue, like we do a elevation of that mucosa, take a snare biopsy, then only we get the result. So it is the visual impression, it looks like cancer, but the tissue acquisition methods are inadequate to take that biopsy.
Yeah.
Yeah,
Can
Dr. Gupta.
Dr. Raman, thank you for an excellent lecture. I just had two questions for you. One is in an altered anatomy. What is your roadmap? Do you do a CT or a barium to know what anatomy it is? Because many times patients just come with a recording which says Roux-en-Y gastrojejunostomy done, but you really don't know what was the anatomy the surgeon decided to bring in. So that was point number one. Second is, do you have an on-site cytologist? Because once you place in a metal stent, then to get tissue is a problem. So most important in cholangiocarcinoma is to get adequate tissue before you put in any stent. So do you have an on-site liquid biopsy assessment or a cytologist who can give you an answer before you actually place your metal stent?
Yeah, great questions. Thank you, Dr. I'll take the second one first. So usually we've gotten, by the time if I'm doing cholangioscopy, I don't even do brushings, so I don't even have an on-site person. I just get histology. So I usually try to take about 8 biopsies. That's usually my goal, if I can, and that's usually it. So I don't, and I will say that for brushings, unlike like for an FNA or something like that with EUS, we don't usually have a person come down for when we do brushing. So in general, the answer is no. Now, to go to your first question, it seems that almost every person has got at least a CT by the time I've heard of them, because that's just sort of almost like the physical exam here in the US now. So we always have a scan, which I usually review. I don't usually get a second scan unless it's very poor quality. But I usually will just review the CT. It's usually a CT, sometimes it's an MR with the radiologist to get a sense of what's going on. And then I find it very helpful if we can get the op note, because that will sometimes give you lengths of limbs and things like that. Not always, some of the notes are not that detailed, but that's the most important thing, I think, even just as much as the imaging is that report.
Yeah.
Thank you. Just a quick question. Do you do well biopsies? Is it safe to do a well biopsy inside the CBD? You know, what Dr. Mohan was trying to allude to, that in linitis plastica, we do a snare biopsy, or you try to get a deeper tissue. Does that have any role in cholangiocarcinoma?
Yeah, I mean, I think when we take biopsies in a region, we usually take about 8. So in some ways, we may be overlapping, which may be what you're saying is the well biopsy, right? You're getting a couple within a region. I don't ever recall having a perforation or anything like that. Plus, we're also going to be stenting anyways, so we'll be kind of providing a bypass and a drain. So I don't have too much concern for that.
Yeah, Dr. Dhawan. Yeah.
Hi.
Dr.
Hi, please.
Yeah, thanks for the wonderful lecture. My question is regarding the tissue diagnosis in unresectable hilar cholangiocarcinoma. So when we are doing ERCP and cholangioscopy in these cases, what's the risk of cholangitis? Because when we are doing the cholangioscopy, we are injecting a lot of water, and if we are not draining all the system, there is a definite risk of cholangitis. On the other hand, we have a modality USFNA. Here, I don't have any risk of cholangitis. So how do you choose between the USFNA or the cholangioscopy for the diagnosis in unresectable hilar cholangio?
Yeah, great question. So it turns out that there was a study in the United States that was done that looked at the rates of bacteremia after cholangioscopy, and not in all comers, whether it's stone disease or, it doesn't have to be, and it's around 8%. So it's actually pretty significant. So we routinely give antibiotics in that situation. Anytime we use cholangioscopy, we always give antibiotics. So it's just, you're putting the scope in, you put the water, there's potential bacterial translocation from the pressure. Going back to your specific question about cholangiocarcinoma and the risk of cholangitis from undrained ducts and so forth, I agree that's something you have to worry about. We definitely try to only inject areas we've already got the wire in. We don't just start at the bottom and just force and perhaps inject the system that we can't get a wire in. I will say that the EUS, you bring up some important points. In the United States, and this may not be an issue for you because in India, the Mayo transplant criteria explicitly say that if you have a transperitoneal biopsy for a tissue diagnosis, that is a contraindication to transplant. And so if you have a hilar stricture, that person may ultimately need a transplant. If you've done the diagnosis via EUSFNA, you may have taken away their best bet at a long-term solution. So we generally avoid a USFNA for hilar, but we do it all the time, of course, for mid and distal duct. But for hilar, we tend to do cholangioscopy for that exact reason.
Great. Thank you. So just a word. I think we are excited to see the excess biopsy, the spy bites, should be launching in India in the next month or two. So I think that will make a big difference in our biopsies. And yeah, sorry. And the other thing was, if we are okay, we can start with the case. It will address some of the questions, I believe, that others may have.
Sure, sounds great.
Yeah, okay. So Bhushan, do you want to go ahead, please?
Yeah, so I'm audible, sir? Yeah.
Yeah,
thank you. Good evening, sir. Just starting a case. So he's a 56-year-old female. He presented in a hospital with a chief complaint of jaundice with itching since last 1 month, which is associated with the loss of appetite and weight loss around 10 kg since a month. And she also complains of a low-grade fever since last 10 days. On general examination, she was icteric, and on per abdominal examination, there was a hepatomegaly, and which was very hard on palpation. So blood investigations showed there is a complete hemogram shows HB was on lower side. Rest of the parameters are normal. Renal function test was within normal limit. Total bilirubin was elevated to 21 with an increased alkaline phosphate to 750. Total protein albumin was normal. Viral markers were negative, and CA 19.9 was 81.79, which was elevated. So she came with triphasic MRI with MRCP. In MRI, we can see that there is an intrahepatic biliary radical dilatation. We can also see some, we can see the liver appears literally non-cirrhotic, and there we can also see there's some hypointense lesion can be seen in the hilar, and liver appears non-atropic and non-cirrhotic. So further visualization of the stricture, hilar stricture, we did an MRCP. In MRCP, we can see it's a complex stricture where right anterior and posterior ducts also appear separated. Further evaluation, like we can see, it is a complex stricture. It is mostly correlating type 4 hilar stricture. Yeah.
Okay. So I'm going to also actually, this is the first time, we'll also actually have a poll, which we will allow the audience to vote. We can just mix it. Yeah, we have a lot of questions, so I'll let people poll. Anyway, so what would be your approach to biliary drainage in this case? Now, it's clearly a complex stricture. It's type 4. It can, obviously in India, especially with our concerns for cholangitis, probably more than the West. I'll have Dr. Praveer Rai, who's here. What would be your approach, sir? What do you think? How would you go about it?
I think the MRCP that we saw has anterior posterior separated and the left separated, so at least 3 systems are straight away in place. I was not sure about segment 2 and segment 3 whether they were uniting or not. So I think type 3 or type 4 bismuth type, PTBD should be preferred over ERCP. If you have type 1 or type 2, then ERCP may be preferred. So in this particular case, I think PTBD should be the procedure to drain 3 systems.
Okay. Dr. Ramchandani, what's your feeling? Do you do a lot of ERCPs in these, or do you prefer PTBDs for type 3 or complex ones?
I think, as Praveer said, in fact, I saw segment 4, 2, 3, all are separated, right anterior, posterior separated. I will not attempt to do ERCP in this because I know I'll do only ERCP with the PTBD backup to have a tissue diagnosis in this. Otherwise, I will not do ERCP in this patient.
Okay. Dr. Singla?
Yeah, it's a type 4 block. I'm really worried about the cholangitis after ERCP in this patient. So I will go for the PTBD and drain the both right anterior and the right posterior duct with the PTBD.
Okay. Dr. Muthusamy, would you, at UCLA, would we have, I guess?
Yeah, I think probably, as Mohan said, that, we probably would be asked to get a diagnosis. So I would probably be in there. Depends on if there was already a diagnosis or not. It sounds like there's not. So I agree that there's a likelihood that you'll end up with ERCP and PTBD, but we probably at UCLA, we would probably do an ERCP we would try to see if we could get a branch, get into the right. Sometimes, even though you look at this, you may get a better sense of what's exactly going in the right hepatic duct when you get in there. So we would probably do cholangioscopy, biopsy, see if we could get the 3, but I would certainly counsel the patient that there's a decent chance you will end up needing a percutaneous drain as well, certainly for the reasons that everyone has said.
Yeah. Bhushan, you can move forward with the options. Okay. All right. Next, just go ahead. Yeah. So yeah, I mean, there's one thought of which I think there's a Korean study of draining the left system across the gastric wall, but they've done hepatogastroscopy for that systems, and then the others they've done with ERCP. So just throwing out the options out there. I understand. I think PTBD is a more popular options amongst most people in this case. I've allowed the audience to vote. So audience, please feel free to vote. And I'm excited to see what everybody has to think apart from the panelists as well. So what we have so far is 51% people would want to do PTBD in this case. ERCP stenting, we only have 16%, 20% ERCP plus PTBD, 11% would like to do ERCP plus EUS guided hepatogastroscopy. All right, so there's a bit of a divide, but preferences for PTBD as of now. All right, so Bhushan, you want to go ahead? Sorry, yes.
I want to point there. I think if segment 2 and segment 3 are separated and you do an EUS guided hepatogastroscopy, you are going to drain only one of the system, maybe segment 3 or segment 2, whatever you choose to. So
Right.
that may not be a great option, especially in this patient had fever. You expect infection in place and you want all the systems to be drained rather than draining 1 or 2 systems here.
Right. No, I think your point is well taken. I think in the Indian context, I think what we see is it's not really about getting the bilirubin down and getting more than 50% of the liver drained, but I think it's the undrained segments which then get jailed off and become a nidus of infection. So I think I have learned over the last year is to really drain it regardless of the volume of liver drained, at least in India. All right, so Bhushan, we'll just share our experience a little bit. Okay, well, that's me and Dr. Muthusamy. Thank you. So I've learned a lot from you. Left is our fellowship times. Right is when you came down to New York before I left. And so hopefully you get to see what I've been able to do here as a pupil. So thank you. All right, next. Yeah. So we have been seeing a bit of hilar cases since 2019. It's been a COVID year, but there have been organic patients that come by. So we've done a total of 50 hilar ERCPs over the last year and a half, mostly males, elderly patients. So what we've seen a bit of a mix, type 1, 9, 11, type 2, 9, type 3 of 3A or B, 21 type 4s, which is what we see more. Next. Next, yeah, Bhushan. Right, so looking, go back. So in terms of what we end up doing, 4 patients, probably a single plastic, 2 patients, double plastic, and then, okay, I can't see the bottom. Bhushan, can you read out?
It is 13 patient, we put a single stent, sir. Yeah.
Single metal, and then
yeah, single metal. 29.
29, yeah. And then a couple of patients, we ended up putting a triple metal stent, which is slightly more challenging. All right, next. So additionally, we performed cholangioscopy in 8 patients, 16%. We had a little more pancreatitis than usual. I think these are tougher ones to cannulate, 16%. Usually our rate is about 6%. They are mild. 1 patient developed ileus. Cholangitis was there, about 8 patients did. 4 patients were unfortunately severe cholangitis with mortality of 4%. 1 patient actually developed COVID, and 1 patient already had cholangitis, a few of them. So 8% was the need for additional PTBD apart after placing the metal stents in our series. All right, next. Okay, so in this case, we chose the other way. We are more aggressive with our ERCP, so we ended up doing ERCP.
Yes, sir. So we decided, and it was a difficult CBD cannulation. Pre-cut technique was used for cannulating a CBD. As you can see, we can use a pre-cut. And finally, we got access into the CBD. Yes, sorry.
Okay.
Yeah, and our single guide wire was inserted using 0.35-inch guide wire deep into the suspected right anterior hepatic duct.
Okay.
Sorry.
So
sorry.
So if we have to get a cholangiogram, I know we are more comfortable in the West with contrast. In India, what's the feeling, Dr. Singla, Dr. Rai?
Yeah.
Do you guys use air cholangiograms, contrast? What's your preference?
So in hilar cholangio, we never inject the contrast. So we'll have the deep cannulation of the duct first, and then we inject the air only, never the contrast. So I think that reduces the risk of cholangitis.
Right.
And,
yeah, great. Dr. Ramchandani, do you use contrast more often or not? Or just air?
Yeah. So now what is the plan in this patient? Plan is to have a tissue diagnosis whether we want it, then whether the patient is resectable or not resectable. What was the atrophy of the left? So we take a lot of inputs from cross-sectional, the of the patient, what is the indication. In this patient has presented to us with fever. So I will not do anything. I know that I will drain this patient. I will take a breast cytology biopsy, put a NBT for some time, let the cholangitis subside. If it happens, again and do air cholangiogram. Then by the time I will have a full assessment, this is a malignant tumor, this is inoperable. My aim is to do palliative stenting. Then in one right anterior, right posterior, that will drain more than 50%. I will not infect the left system. So I'll take a lot of help from MRI and will not depend on contrast injection at all in this patient.
Yeah, this patient actually was inoperable and there was no atrophy of the duct. So we, that was just as a background. Okay, and now, so we have now, say, a wire in the right anterior. We need to get access to other ducts, at least. We are planning to drain the 3 systems with ERCP in this particular patient. So what's your preferred choice of wire? What do you guys use usually? I think a good technician is important.
Always we use short wire, which are hydrophilic, and we use a lot of Teremo for selective selective cannulation of the desired duct. And once we get deeper inside, then we exchange with the wire for accessory exchange. But for initial access to selective cannulation, we use a short Teremo angulated tip.
Yeah.
I think for the right anterior, the straight wire is good. For the right posterior and the left duct, you need angled
tip wires. So Dr. Mutsutami, we used to use a Navipro. Craig, our expert technician, and
right. Yeah. I agree with everything that was said, because I think it's usually a straight shot into the right anterior, so that's that's a good. But for the others, we tend to use angled wires as well. Just our manufacturer, we tend to use an angled Navipro, and then exactly as was said, there's once you get deep access, you can exchange for something you can stent over.
So if Teremo somehow, if it doesn't go, the other wire that we commonly use is an 025 VisiGlide wire. So that's the other wire that we use sometimes to gain access.
Yeah, I think looking at the audience poll, we asked the audience what is their preferred access wire. 67% would prefer angle tip Teremo wire. Next is 23% Visi. 8% would use a standard 035-inch guide wire, and other was like 2%. Okay, all right. So we can move forward, Bhushan. Thank you.
Yes, sir. So we achieve access into right posterior duct by using a 0.53-inch guide wire. But access to, as we can see, access to the left hepatic duct was not possible despite multiple attempts using an angle tip guide wire. And we also tried with another guide wire like VisiGlide 0.2-inch, and we can't able to cannulate a left hepatic duct.
Okay, next. Okay, so now we are in here. We're trying to get access to the left duct. What do you guys technically do? Just try. I know Dr. Muthusam used cholangioscopy to use it. I haven't had much success with it, plus minus a couple of cases. So.
Yeah, I mean, I guess you're right. I mean, sometimes it's very difficult to see anything, and so you may not. But since I'm often there anyways to get tissue, Sometimes what I'll do is I'll use the cholangioscope to try to get wires in each system, and then use it, and then come out, and then we'll stent. So that is, since we're already there. But as you say, some of these are very, very difficult, and I do tell patients, and as we know, that a large percentage of these patients will end up requiring some component of percutaneous drainage, right? So pure endoscopic drainage on hilar cholangios is not always the norm. We need to understand that.
Right. So, Dr. I, Dr. Singla, do you guys have any thoughts? How do you
Yeah.
what do you do in these cases when
I think
it's a little hard?
here, the case we are talking of, segment 2 and segment 3, are they united or not?
Yeah.
Are they united?
Yes.
Yeah.
So if they are united, and so we need to consider whether the patient is operable or inoperable. So if we are talking of inoperable disease,
Inoperable.
unresectable, then I think segment 2 and segment 3 are uniting. Then US guided drainage is an option. We can do an US guided rendezvous, or we can do an US guided hepatogastroscopy. So either of it can be done. If we are able to pass a wire easily, that can be tried. But with hilar stricture, normally it's difficult. The wire doesn't go down nicely, and hepatogastroscopy may be an easy option in this particular case. That is what I would try, rather than doing an PTBD at this point of time.
Right.
Yeah, in this patient, it's an unresectable cholangio. So I will place 2 metal stent in the right anterior, right posterior, and then stop the procedure. And I will follow up the patient. If the patient has persistent fever, then we may have to drain the left lobe also. The option will be either doing a PTBD or the US guided hepatogastroscopy.
Right. Okay. Yeah, Dr. Ramchandani, do you have any tips of getting access to the left duct if your regular methods are not trying to do something?
I definitely, in this case, I agree with Vikas that we will stop at right anterior and posterior, because I saw the left anatomy too complex. I saw 4, 2, 3 all separated, and there is no point in cannulating left. And as Vikas told, if the persistent cholangitis, we may intervene with PTBD. But in other cases where we really want to cannulate left hepatic duct, I will definitely take help of cholangioscope and try to manipulate wire with, and also will try to use different, maybe sphincterotome. Sometime I use ball tip, sometime I've used Haber ram to just do many maneuvers. Especially sometime I use balloon, where I stretch the balloon in the mid hepatic duct and then try to change the trajectory of wires. So not only wire, but also the delivering catheter can be changed to access to the left hepatic duct. Cholangioscope may be the last option, but if all fails, I will agree with Praveer that if all the systems are communicating on the left side, it is better to drain internally by hepatogastroscopy rather than going for PTBD.
Yeah. No, I think that's a good point. I think we can use different cannulas and tomes and bow the tome to get the right angle. And yeah, so Bhushan, we can move forward what we did in this. What we
Yes,
did.
sir. Yes, sir. So we pulled that anterior duct wire, and then we obtained an air cholangiogram. And then we have on the re-access that finally we can able to recannulate this left hepatic duct with using a VisiGlide wire. And then subsequently, we also able to cannulate an right anterior. As you can see, a right anterior duct can also able to cannulate. So we finally achieved a cannulation to all the 3 duct system.
Yeah, I think one thing we sometimes do is when we have a wire in the right anterior and the other ducts not getting access, we end up pulling that wire because somehow in our experience, just that wire seems to interfere in our experience. So we just ended up pulling this wire out, and then once we got access to the left duct, then we could place it in. I mean, it worked for us in this particular case, but obviously, I mean, it can be really challenging, and then we have to just like give up. Okay, next. So just sampling techniques. I mean, I know this was felt to be a cancer inoperable. Additional cholangioscopy, Dr. Muthuswamy, you did mention that you routinely do perform, and because they are referred to you. How about Dr. Ramchandani? Do you end up doing cholangioscopy in most of these, or just brushing plastic or stents and then take it later?
Well, the major problem with cholangioscopy in complex hilar stricture is cholangitis. And you know that there is a lot of water insufflation to be done. And then, we end up with severe cholangitis, especially in India. So I try to avoid doing cholangioscopy in this patient, especially in hilar. I'll exhaust my other traditional method of tissue acquisition like brush and biopsies, rather than to do cholangioscopy. Or at all, if I'm doing cholangioscopy, I'll make sure that I'll not inject too much of contrast, or I'm already very sure that I will be able to drain all the systems.
Right.
If I'm very sure by that cross-sectional imaging that there are no separations, major separations, and there are only 3 systems, I still do cholangioscopy. And I know why I am doing tissue acquisition. Now I have a good and cross-sectional imaging saying that this cancer is inoperable and patient is not a candidate for, let's say, chemoradiotherapy later on. Why I am doing that? Or if patient is operable, then why to infect the system? So operable, inoperable, that is one. Whether the patient is candidate for a new this chemoradiotherapy also comes in question. Whether strictly you have to do too much of efforts to take tissue required or not. But if required, I will do stepwise. Like I'll do traditional method and cholangioscopy only when I am very sure that I will be able to drain the system.
Yeah, I think that's a point well taken, and definitely in the Indian context with infection risk, it's worth, you have to think twice. Dr. Singla, do you have a similar thought?
Yeah, it's a type 4 cholangiocarcinoma.
Yeah.
And type 4 mostly they will have a large mass lesion on the imaging. So I prefer doing a USFNA in these patients, and I will get the tissue diagnosis. So when the diagnosis is confirmed, I will go with the ERCP, and then take the brushing if required. And sometimes we pass a 10 French sheath in the CBD, and through the sheath we pass a pediatric biopsy forceps, and the biopsy from the stricture side.
Yeah, I think that's something we have tried as well. It does seem to give some tissue. Obviously, it's not very directed, but it's still better than brushings. Agree. So we asked the audience as well. They say, do you perform cholangioscopy at the same time in such cases? About 40% audience seems to perform it. 23% no. Another 40% don't have it available. So no. Okay.
I think a point in proximal lesions, hilar lesions, cholangiocarcinoma, or because of carcinoma gallbladder, I think we have sufficient data to show that ERCP, brushings biopsy, or a spyglass biopsy is better than doing a USFNA compared to a distal lesion. For a distal lesion, USFNA is the first choice rather than doing an ERCP guided brushings of biopsy or spyglass. So for proximal lesions, ERCP guided brushings plus biopsy, because that increases the yield to around 70% compared to if you do alone, which may be just 50% cytology alone, biopsy maybe just 40-50%. But if you combine those, it increases the yield to around 70%. So that may be the first option rather than doing an USFNA for proximal lesions.
Okay, thank you. Okay, Bhushan, next. So now let's say we have access to the different systems. We need to dilate the stricture to get access, to put the stents. What's your preference in terms of boogie, the size, balloon, choice of diameter? How long would you inflate the balloon for? Any evidence one way or the other?
I always use Titan balloon, 4 mm to 6 mm to dilate the stricture and keep it dilated for 1 minute. Sometimes these boogie are difficult to pass, but if a good Titan balloon or the 6 French delivery catheter, they are easy to pass, and then you can be able to dilate this, especially the complex stricture. So my choice is balloons rather than boogie.
Yeah.
So I think we uniformly use a 4 or 6 millimeter hurricane balloon. That's the first choice that we make.
Okay, fair enough. Bhushan, next.
Yeah. So yes, as we say, after achieving the access and after taking brush cytology, we start sequentially dilating the stricture on the left side, sequentially in the left hepatic duct system by using hurricane up to 4 mm, and dilated the left hepatic system and also the stricture on the CBD CSD area, and then into the, as we can see, a right anterior duct system, and then into the right posterior duct. So we sequentially dilated with 4 mm hurricane balloon. Yeah.
Yeah. Okay. Nice. So yeah, I think we did allude to this, but now that we're here, Dr. Ramchandran, you did mention you'd like to use MBD in these cases with some cholangitis. Bilateral plastic or 3 plastics, 3 metals, 2 metals. I think we do have access to the ducts now. Choice.
I think that depends on, there are some studies showing that if the patient survives for more than 2 months, it's always metal stent cost effective. But later on, we are seeing meta-analysis showing metal are always better than plastic, because if you are seeing the initial cost, the metal may be more, but the patient keep on coming back with cholangitis, recurrent plastic stent exchanges. So ultimately, I think metal stent is the best option in such situation.
Yeah. Yeah. Especially, I think in India, I think in our prior experience, we've seen patients have bad cholangitis after plastic stents, making us a little more wary of using the plastic stents. If you're intervening, that our preference has been to use metal stents, as we sort of mentioned earlier. Dr. Rai, have you used plastic stents with much success?
I think we have possibly around 75 to 80 patients of carcinoma gallbladder with hilar blocks.
Yeah.
And I can uniformly in all these patients we have used metal stent, provided the performance status is okay, and those are the patients we take up for ERCP and metal stenting. So for me, unresectable blocks, it's almost always metal stents if we are starting with the procedure.
Yeah, yeah.
Yeah, I agree that in the type 4 block, I think the metal should be placed, uncovered metal.
Right, right.
Yeah.
Okay. So I think I did ask the audience as well what their thoughts are in type 3, 4, not this patient, but type 3, 4 bismuth strictures. So nobody would want to place 1 plastic. 1 person would want to place 1 metal. 2 plastics, 24, that's 45%. 53%, 2 metals. Well, not in this case, but type 3 or 4 strictures. So it's a little more popular. And I think I just, also the prior question, what do they use for dilation of hilar stricture? 43% in the audience would use Sohendra, Boogie, 23% balloon, others 34% don't dilate. So I'm not sure we all agree with that, but most of us will want to balloon dilate these strictures. Okay, next. Bhushan.
Can I have a comment?
Yes.
Yes, sir. Yes.
Yeah, actually, there was one paper in GI endoscopy published very recently, I think in the last year, which has compared the bilateral metal versus unilateral metal versus bilateral plastic and unilateral plastic, and it has clearly shown benefit of bilateral plastic in terms of efficacy, survival, re-interventions, and all the parameters were better in bilateral plastics, and metal stents were better than bilateral metal over bilateral plastic, as well as unilateral metal is better than plastic.
Yeah, yeah. Okay. Thank you.
Yeah, I guess I will just maybe to be the contrarian here. So I think that the sweet spot for the metal is you know, if you're going to live more than 2 months, but perhaps not more than 6 or 7. If you start getting into a year, you know, 18 months, and we're seeing more and more of that, the re-interventions on the metal become difficult. Obviously, you try to go transpapillary and have each system, the right and left, separate. So I think it's interesting to hear this discussion, because in the US, I would almost guarantee that if you had the same discussion, you would hear mostly plastic, mostly because of the durability and the improvements we've seen in some of the chemotherapy.
Yeah, yeah. Okay. Next, Bhushan, we can go on.
Yes, sir. This configuration of metal stents, what do you prefer?
So yeah, now there are, so we do have the side-by-side configuration, or the stent in stent, which is, I believe there's the Taiwan has that stent, which, right? Yeah.
Yeah.
So I'm not even sure, because we have used the side-by-side technique. Is that even available in India? The stent in stent Taiwan one?
Yeah, they're available. They are from Nitty stents. They are large cell design, which has got the interstitials of 7 millimeters.
Right.
So you can go through that gap to any, you can place 3, 4 stents through one stent. So
Right.
and also the radial force is almost equal to the small cell design.
So
Yeah.
I
Dr.
think,
Raj, what do you use in
yeah,
these cases?
I think we have tried both actually, and I think as far as literature goes, there was a Korean study 2012, which suggested that there was no difference between side by side and stent and stent. This
Yeah.
was as far as success of drainage, early complication, late complication. After that, there was another study which showed that the complication rate was higher in side by side stent. However, the patency was longer in that group. So this is what the literature is.
Okay.
So at this point of time, at least in our center, we are using side by side.
Yeah.
Yeah, I think if there is a stent blockage, then the reintervention is easier with the side-by-side stent.
Right.
If you do it-
Absolutely.
Yeah. Okay. Next. Okay. Now that we are placing side by side, which stent do you end up placing first? What's your preferred? Now, in this particular case, you have the left and the right and posterior and the anterior. Well, just for the benefit of audience, how would you want to approach it? Yeah.
So I think once we have 3 wires, usually we end up placing first the left stent.
Yeah.
So left is the first that we place, then right anterior, then right posterior. This is a sequence which we follow. Sometimes it happens that once you have placed 2 metal stent, the third one, right posterior, becomes very difficult. The stent becomes very difficult to go. So
Yeah.
in those cases, somehow we end up placing a plastic stent as well.
Okay.
But this is the sequence that we follow.
Yeah.
Yeah, I think the right posterior is the most difficult to place. I will go.
I think I agree. Yeah.
Yeah, and the right anterior is the easiest. So right posterior should be first, and the right anterior should be the last because it's more straight.
Yeah.
Left and the right posterior are more curved, so they should be attempted first.
Yeah, I think I agree. I think the right posterior somehow the configuration makes it more difficult. We do start with left certainly, but now it's right posterior, and if depending on the tightness and the ability to push the catheter across, then I think we have a choice between starting right posterior or left. That's been, yeah. Okay, next Bhushan. So now the simultaneous deployment epic stent is available. So do you guys use that? You start with one and then deploy the next one, or do the simultaneous deployment? What's been your feeling, Dr. Muthuswamy? Do you use is it available now? I remember during my time it wasn't. So
yeah, I've used the Epic stent a couple of times. I generally like to do them if I'm only placing 2 stents. Obviously, if I'm doing 3, I would probably just do them sequentially. But if we're doing just 2 and it's metal, I generally try to use the side by side in the Epics in parallel. I will say though that I found that it's really hard to see the Epic stents. I haven't been in love with them, to be totally honest with you. So in general, we've been kind of mostly just going sequential with that. But I like the concept of placing them simultaneously, but I've had some difficulty seeing and in terms of the deployment. And as I said, we are using less and less metal in general, so we don't have a huge experience. Yeah.
Yeah. Anybody has more preference for simultaneous deployment versus sequential? Yeah.
I think we agree with Dr. Raman that if 2 stents are there, then obviously the simultaneous deployment become easy. But for 3 stent, it is almost impossible.
Right. No, of course. Yeah. I think in our experience as well, when we did start simultaneous sort of sequential, and then we did use simultaneous deployment for a period of time. But then I think there is a lot of resistance putting 2 6 French catheters across. And then loading them across the stricture became tough. So now we have switched to sequential again now. So yeah, that's been our experience at least. Okay. Yeah. So of course, place all the SEMs across the papilla, preferably, or you guys are okay with not?
I think it should be all across papilla, because if you want to the only advantage of putting parallel stent is re-intervention. And if you want to do re-intervention, all the metal stent should be out of papilla.
Right.
Even if your one stent is inside, it is almost virtually impossible to go into that stent, because the expendable stent of the stent which is outside will cover the opening of the previous stent. So it is mandatory to keep all the stent outside if you are planning for re-intervention. Otherwise, the success rate of drainage, whether it is inside or for the index case, for the index time, is equal. But for re-intervention, it has to be outside.
Problem. Yes. Okay. All right. Next, Bhushan.
Yes, sir. So after dilating all the system, we sequentially put the stent first into the left hepatic duct, as all space that left hepatic is more angular, and then subsequently into a more right posterior duct. As you can see, we can down dip, and finally into the most straighter duct, that is the right anterior duct.
Okay.
Yeah.
So yeah, I think we
word of caution for everybody, and I had personal experience. Recently, yesterday, I was doing one case where I thought I'm cannulating right anterior and right posterior, and the patient had severe cholangitis. Then I did a CT scan, and I saw the stent which was in the left was in segment 2, and which the right anterior, which I thought was actually in segment 4. And the right posterior was in fact right anterior, and right posterior was not drained. So there is on this two-dimensional anatomy without a proper contrast, it is, and type 4 stricture, one cannot be very sure about the drainage. So so that is a word of caution, which is my personal experience.
No, I think we've also experienced something similar. I agree with you. I think what we have ended up doing is, before placing the stents, we put them supine, and then from prone position, get them supine sometimes, and get another X-ray to make sure we are actually in the systems that we are before deployment. Is that everybody else's feeling as well?
Dr. I think sometimes it becomes difficult, especially you think that it's right anterior and you have stented segment 4 duct. So that commonly happens.
Yeah, that can happen. No, that's true.
Yeah, I think it's better to have MRCP film during the ERCP, and that may guide having the MRCP film.
Yeah. Okay. All right, next. So it's the role of radiofrequency ablation. Dr. Ramchandani, I know you've done a lot of work in this. This is all pre-metal stenting, of course. Do you routinely perform in select cases?
We do perform this quite often because our is a private institute and also depend on many other factors. But we do perform in patients who are not resectable, and we have seen improvement in stent patency, even the quality of life, and also in fact some of our fellows are doing thesis on this, and we'll be publishing a randomized control trial maybe next year or so. But we find this as a very good modality as an adjunct for a better palliation in unresectable cancer, in addition to the metal stent.
Yeah. Okay. So actually, we can answer a couple of questions from the audience. Any indication of biodegradable stent and hilar stricture by Dr. Rajendra Patel? I don't think so, right? No. Yeah, everybody seems to say no here. Dr. Anurag Jaina is asking, what's your protocol for amount of contrast injected in hilar strictures during cholangiogram? And what about pre and post procedure antibiotics? So yeah, I think everybody would use antibiotics. Dr. Muthusamy, I think you mentioned that. So you would inject once you are in the system, and be very selective in obtaining cholangiogram.
Correct. You follow the wire into where you're into, because then at least you have access. If you just start at the bottom and do a forceful injection, you may end up filling up a bunch of systems you may never get access into. And then now you've got a real problem. So we tend to let the wire try to cannulate a system, then follow it up with the catheter, then make the injections, and then make the assessment from there. And use the least amount of contrast as possible. If you think there's cholangitis, you may even want to aspirate before injecting to avoid, the pressure increase risk for translocation.
Okay. Dr. Tarun Bharadwaj is asking, how exactly do we do CO2 cholangiogram? I guess we use air. I think the amount of air is very little. That's the feeling that air. Do you think there's a risk of air embolism with the little bit of air that we push in?
I've never seen. We've been doing this air cholangiogram since long, and never seen air embolism.
Right. Yeah, I think we've never seen it as well.
More of a theoretical risk, not practical.
Yeah,
Well,
the air embolism that I've seen
right.
reported really was with that anchoring balloon that they had that was used for those peroral cases, right? I think that was where, but I think that got everyone's attention, and we've all
Yeah.
been a little bit, cautious.
And Dr. Uday Somshekhar is asking, why do we have a higher incidence of cholangitis after PTBD and plastic stents in India compared to the West? Seems to be the experience across all centers, including tertiary centers. Yeah, I think it's annoying that it's there. We've tried a lot from our end to do everything before hilar cases, but still we've experienced that. Any thoughts? Dr. I, Dr. Mohan Ramchandani.
I don't know whether that's a correct statement, whether the incidence in India is higher than West. We don't have any comparative data, but I think if you are meticulous in draining each and every segment, that is the first thing. And obviously, in the cultures and other things will be important. But the most important is the technique and not infecting undrained segments. If we follow that principle, most of the cholangitis can be managed by antibiotics.
Okay. Yeah, and then there's a question for type 4. Do you prefer air cholangiogram or still inject contrast? Air mostly, right? At least from all of us. Yeah. What is the best way to handle tumor ingrowth of a biliary stent? RFA.
In fact, we were doing a trial by Cholangioscopy. So we don't know once a patient comes with block stent, we don't know what is the cause. We need to assess the cause. Majority of the time, it is the sludge and will not require any ablative treatments. But once you have said that it is the tumor in growth by methods like cholangioscopy, in our series we found that around 40 to 50% of the patient were because of the sludge, and it is not the tumor in growth. Patient has come with cholangitis or a stent blockade, but we don't know the cause. But once we have made it certain that it is the tumor which is infiltrating, then there are option of doing radiofrequency ablation or putting another stent.
Yeah. Dr. Aditya Kai.
The cause is important. Why there is a block?
Yeah, I think it's important to do balloon sweeps to just see if there's sludge and which can be removed, which is often the case, as you said. Dr. Aditya Kari is asking, do you change fluoro position to determine the wire positions during difficult ERCPs like this? Yes, we do. Do you all do as well? Sometimes, I mean, it's cumbersome to make the patient prone to supine or change the, I think in other centers which have nicer fluoros where you can move the bed as well. Probably get a better view.
I think best view is obtained by supine.
Yeah.
All the anatomy. So
that gives us.
If primary position of doing ERCP in hilar stricture should be supine rather than prone.
Yeah, my only issue is I think just loading those stents can be a pain in supine sometimes. That's my personal experience.
I think that you have to change your position to extreme right and turn the small knob to right. You almost have to see towards their back to keep the stent position stable once you are doing supine position. But anatomy which is seen on fluoroscopy is much better. The ducts are better separated and you have better delineation of individual ducts on supine rather than on prone.
Yeah, no, my point well taken. Dr. Tarun Bharojaj is saying, which lubricant is used to reduce friction between placing sequential SEMs? None. Anybody else uses something? No. I think it's surprisingly, it goes in more smoothly than you would guess is my feeling. At least initially, I don't know, after a point that when the stent expands, but okay. All right. So I think Bhushan, we can move forward because we are late in the day and surgical issues. I mean, if it's a resectable case, now we're in India, you don't want to use plastic, probably PTBD in a surgically resectable patient. I
think that is why it is important to, first of all, spend more time in knowing the whole history of the patient, studying cross-sectional anatomy, patient being even if there is a young patient who has the slightest doubt, if the preoperative probability of malignancy is high and your repeated tissue diagnosis is negative, still you give a chance of doing surgery without putting metal stent rather than putting metal stent. So that dictum, if followed, will not have these surgical issues with metal stent.
Do surgeons in your institutions have problems with a metal stent placed if they are doing hepaticojejunostomies down the road, say in a couple of weeks?
Yeah, so I think as far as our center is concerned, all hilar blocks, if they're operable, we never place metal stent. It's always plastic stents, ERCP or PTBT, whatever it is. For distal blocks also, because of the cost issue, we end up placing a plastic stent for sure. So I think in our center, resectable disease, plastic stents.
Right. Okay.
I agree. Hilar cholangio resectable, no use of metal stent. Only the plastic stent should be used.
Yeah.
But for lower stent now, there is a dictum which is followed is neoadjuvant chemotherapy in all cases. So one has to use metal stent that gives a better preoperative biliary. And if a Whipple cell is planned and if the stent is short, I think surgeons always agree with that. But as I agree with Vikas and Praveer that for hilar, they have many issues if the stent goes deep into the hepatic segments.
Yeah, Dr. Mohan, are you using neoadjuvant for all the resectable lesions?
Yes, now we are using all neoadjuvant. And
for borderline, if it's clearly resectable,
even if it is clearly resectable, for CA pancreas we are using. I don't know what is the now what Dr. Raman is following there in US.
Oh, that's interesting. People have talked about that. I mean, unfortunately, as you know, we don't get very many clearly resectable pancreas lesions, so it's a small minority. But those patients still typically go to surgery, and that's the only group that, if preoperative drainage is needed. So I mean, if the bili was 6 and it was small, usually our surgeons just want it under 10, and if it's 6, they may go straight to operation. If otherwise, we'd place a stent and usually a plastic, but everything else, as you said, is a fully covered metal. And again, there's lots of studies looking at should you do partially covered, uncovered. They're all basically the same in terms of you just change stent overgrowth for ingrowth. So it's basically a push, but usually we place a short metal stent for anyone undergoing neoadjuvant.
Yeah. Okay. So we can answer a couple of questions. Just in a few minutes, we'll wrap it up. Dr. Yogesh Shastri is asking, laser fiber is difficult to bring out of a spice scope. Any practical tips? Yeah, it's a pain, especially if it's been used a couple of times. What do you guys do?
I think better to have a good balloon sphincteroplasty first, so that you do not require a wire to be, the spy to be railroaded on wire. It can go with a free hand. And if there is a good balloon sphincteroplasty and the lower sphincter is well open, you have to preload the laser fiber right up till to the tip, and then go with free hand. Do not use wire first to reach to the top and remove the wire and then put the laser probe. It is almost impossible to pass through the angulation. One day it will stuck at the elevator site, and then again it will stuck at the bending section of spyglass cholangioscope. So we use this technique of preloading it rather than passing the laser fiber later on.
Yeah, thanks for mentioning that, because I think we had a similar experience. We had a small perforation when we were doing freehand in such cases without sphincteroplasty. So now we have, as a protocol, we do sphincteroplasty in all the patients before advancing the SPY freehand, because problem is with the kinking to get these instruments up, you have to do, as Dr. Ramchandani mentioned, pull the SPY scope back into the scope channel, get the accessory till the tip, and then go freehand. Thank you.
Yeah, we use a 200 micron fiber. That's easier to bring out of the SPY scope. And other thing we follow is that we go higher up towards the hilum. Then it's easier to bring the laser fiber out.
Oh, so what do you think about changing the scope position, going in a long position and having a sort of straighter angle? Does that help?
Yeah, but my preference is that it's difficult to bring the fiber from the angulated part. When the angulated part of and the scope is towards the ampulla. It's difficult to bring it out. So once you've taken the angulated part up to the hilum, it becomes straightened.
Yeah. Yeah, and I think good you mentioned the 200 micron does seem to go better than the sort of larger one. Although, yeah. Do you think the efficacy of the 200 microns is lesser than the other one in terms of lithotripsy for all those who use laser? Yeah.
For the practical purpose, even with the 200 micron, you can deliver the high energy.
Yeah. Okay. All right. Dr. Arul Prakash is asking, deploying another stent for tumor ingrowth should be covered or uncovered?
I think it should be always uncovered. Covered stent will migrate very fast because now there is no stricture there because it has been taken care by the previous stent. It is like it will be free fall for the second covered stent. So I will prefer still an uncovered stent in this situation.
Yeah.
For cholangio, for sure, and even for pancreas, this has been looked at actually multiple times. Covered stents do not have increased patency for basically you're changing ingrowth from overgrowth. So basically, it doesn't really. I agree, uncovered.
Yeah. All right, and maybe a last question. Dr. Karthik Goyal is asking, maximum length of metal stent available is 10 centimeters. How to deal with length of stricture in these cases? Because your target is to bring your proximal end at least 1 centimeter below the ampulla for further intervention. Yeah, I think that can be a practical challenge. Right. I don't know if anybody else has any thoughts. I guess I think it's more important to ensure the adequate drainage than getting it across the papilla. If we are in it.
You can do overlapping, right? So you just, once you have the wire, you just overlap it to your cross.
Yeah. Okay. All right, Bhushan.
Last, can I make a comment?
Yeah.
Yeah, actually, in clinical practice over a period of last 35, 40 years, what I have observed is when it comes to cholangiocarcinoma, many of the resectable lesions are missed and passed off as a palliative lesion. So I think an importance should be given to multidisciplinary approach where a radiologist and the surgeon and the gastroenterologist, they sit together and find out at the first place whether it is operable or inoperable before going ahead with intervention. And this has to be followed because otherwise salvageable patients are written off as a palliative cases.
Yeah.
That's a great point. And we've had a few cases at our center where the MRCP suggested it was a type 4. And we have done cholangioscopy and shown that there was some debris and material that was being called tissue as obstruction and was overstaged. And we actually said, no, this is either 3A, 3B, something, which made them a candidate for resection. So that's a great point.
Yeah. Oh, thank you. And I think with the advancements in hepatobiliary surgery, I think it's a little underappreciated that some of these type 4s can actually be resectable, which is not commonly thought as in most situations historically. So yeah, I think that's a good point. And okay. So I think Bhushan, we can just wrap up. Yeah.
Yes, sir.
Okay.
So post ERCP, patient has just mild acute pancreatitis, which was managed conservatively. Total bilirubin has reduced to 16 on day 3 from 21, and after the 1 month patient has followed, that patient bilirubin has dropped out to 3 milligram per deciliter. Patient came, breast cytology was positive for adenocarcinoma, and patient was discharged subsequently.
Yeah.
Thank you.
All right, we can. Thank you. So there is Endocon this next weekend. Dr. Ramchandani is going to be participating as well. I have the pleasure of talking on the latest in EUS. So do tune in, and it should be a great conference. Next slide, Bhushan. And then following that weekend, we'll have another session. We'll have Dr. Nicholas Talley talk about new insights into dyspepsia. He's a world authority. I don't know, he's probably had like 1,500 papers in dyspepsia. So we look forward to hearing from him the next, there'll be 2 weeks from now, but that'll be at noon because it's Australia time evening. So it'll be noon India time. So just so all of you know, it's not going to be in the evening. Okay, so I think we can wrap up the session there. Bhushan?
Yes, sir. Thank you. Yes.
Okay.
Okay. So, thank you, Dr. Mukevar, Saurabh.
Thank you. Thank you. Thank you, Mohan.
Mohan, sir.
Yeah. We'll
Good
have
night.
Dr.
Thank you,
Datta,
everybody.
come on the next session with Dr. Talley. So we look forward to having you, Dr. Datta, for that. Thank you.
Yeah. Good night.
Good night, everyone.
Thank you.
Thank you, Dr.
Night.
Rai,
Thank you.
Dr. Chandani, everyone, for your great input. Thanks, Dr. Muthusamy. That was wonderful. Great having
Thank
you.
you so much. Good to see everyone. Thank you.
Thank you.
Thank you.
Thank you, Mohan sir.
Thank you.
Thank you. All the best.
Yeah.